All right. So like I said, we want to look at history taking. All right. How do we take history? Now, when we look at history, all right, here so I'm trying to also be allowing some people that are joining in to allow them in the meeting. So you pardon me if I'm pausing here and there to always respond to requests to join into the Google Meet. Okay, so when we look at history taking, number one, we look at the general, okay, the general aspects. Then we also look at systemic, okay, systemic. So under systemic, we look at respiratory system, okay. Then you look at the cardiovascular system. Then we have the GIT, okay, GIT and GUT. Usually, these ones we consider them together, all right. And then we also have CNS, okay. But for purposes of today's discussion, we are going to concentrate much on the general aspects before we can go into the systemic, right? So that's what we're going to try and do today. And I think we started a bit late. I have some other programs that I need to attend to. All right, so let's get into the general aspects of history taking. By the way, uh, what we should understand before we can even go into history taking is that around 70%, okay, around 70% of your diagnosis will come from history. Okay, so a good history, okay, is going to give you about 70% of what of your diagnosis. If you take a very good history, there are actually some conditions that you can make a diagnosis entirely from the history that you've taken. All right, and then probably other about 20% of the diagnosis is going to come from physical examination. Then only about 10% is going to come of your diagnosis is going to come from what? From investigations. Okay. And when we say investigations, here are talking about laboratory and radiological investigations. All right. So in other words, what are we saying? The investigations, that is the laboratory and radiological investigations, okay, and histopathology if need be, those are just going to be confirmatory, just going to help you to confirm the diagnosis that you have made. What I'm saying? What I'm saying is that a bad history, if the history that you've taken is good, okay, bad history is going to make all these others to be almost useless. Let me give you an example. A patient has malaria, right? If a patient has malaria, okay, I'm giving that example because it is probably one of the most common conditions in our setting. Okay, so if a patient has malaria, and then let's say, for example, you say, okay, this patient, instead of you thinking it's malaria or making a diagnosis, a clinical diagnosis that it's malaria, you think of just something else. Maybe you think it's maybe let's say stroke. All right, you say it's stroke. It means that when you start your investigations, your laboratory investigations, and your radiological investigations, all those are going to be targeted towards what? Towards the stroke that you're thinking about, isn't it? And then you're going to miss out on the diagnosis of what? Malaria. Okay. So a good history guarantees that you're going to come up with the correct diagnosis. Now, why is it important to come up with the correct diagnosis? It is important to come up with a correct diagnosis because if you make a correct diagnosis, then you're going to manage your patient correctly. Okay, a patient with malaria are going to give drugs that are going to help that patient. You're not going to give that patient drugs for some other condition. Okay. Now, when you make a diagnosis, there is what is called the definitive. There's what is called the working diagnosis. Okay. There's what is called the working diagnosis. The working diagnosis, or in other settings, they call it the impression. Okay. or the impression. Working diagnosis or impression, this is the most likely, okay, the most likely what? Diagnosis. Now, this is from clinical diagnosis. Clinical diagnosis meaning that combination of history and what? Physical examination. Once you do your history and physical examination, okay, first of all, just from history alone, you should be able to come up with a working diagnosis and, or rather, what is called the impression. What you think is most likely affecting your patient, okay. Then from there, you also come up with what are called differential diagnosis, okay. Differentials. So differentials are alternatives. All right. Alternatives. Alternatives meaning that if it is not what at it is most likely affecting the patient, then you say it could be this, or it could be this, or it could be that. Okay. Something that these differential diagnoses, they have signs and symptoms that are closely related to what you thought is the diagnosis in the first place. Okay. For example, if you think a patient has malaria, which other conditions are going to present with similar but not the same signs and symptoms as malaria? You get the point. So that is what those are what are called the differential diagnosis. The conditions, okay, that have signs and symptoms that are they are similar but not the same as the diagnosis. So the first one you make is what is called the impression or the working diagnosis. All right. So you say that this is mostly what is affecting my patient. Okay. This is what is mostly affecting my. Then from there, you also come up with what? With a differential diagnosis. Now, in most cases, as a student, as a medical student, in most cases, coming with impression of the working diagnosis, okay, it is important to come up with as much as 5 different. The reason why that is just important is it encourages you to think widely. Okay, it means that widely. You're thinking of this condition, think of this condition, you're also thinking of this condition, and trying to put them together to see how they are related to the condition that is most likely affecting. Okay, so in other words, the only reason why you need to come up with as many conditions as many differentials is so that you can think broadly and don't miss out on anything that is important that may be affecting your patient. Okay, are we clear so far? Is there any question from anyone before I proceed? So I've not yet gone into the history. I've just done a bit of introduction. Is there any question, anything from anyone? Can we proceed? Please, while you need to respond, you always respond. I said you mute your mic. You can mute your mics, but when I need you to respond, please respond. Okay, so we can move forward, guys. So that is about working diagnosis and differential. Now, after you do your investigations, okay, after you do your investigations, then you are going to come up with what is called the definitive what? Diagnosis. The definitive diagnosis. So the definitive diagnosis is something that is confirmed. Diagnosis that is confirmed by laboratory or radiological what? Radiological histopathology, okay, and so on. You understand? So now, how do you come up with the confirmed diagnosis? Okay, how do you come up with that? Now, in your diagnosis and differentials, you've listed maybe about 5. Now, how you order the investigations that you need to undertake for you to confirm the diagnosis of your patient? You need one. Okay, one, you need to order investigations that are going to confirm, okay, or we say or rule out, rule in or rule out differentials. Okay, so you have differential diagnosis. So there are 5 of them, right? Then including the working diagnosis or the impression that